Welcome to Healthcare AI Weekly. This week, two papers pull healthcare artificial intelligence in two directions that have to meet in the middle: the speed of clinical triage and the accountability of community governance. The first paper asks whether routine triage data and electrocardiogram interpretation can help prioritize suspected cardiac patients. The second asks who should shape artificial intelligence in healthcare systems, especially when communities have long histories of extractive data practices. The clinical paper is from Bavali-Gazik and colleagues in European Heart Journal Digital Health. It studies 600 suspected cardiac emergency department records. The useful teaching point is multimodal clinical artificial intelligence, structured triage data, plus electrocardiogram interpretation. Figure 1 shows the workflow. Think of it as 3 lanes. One lane learns from routine triage information, one lane learns from ECG interpretation, and the final lane combines both. This is not a chatbot paper. It is a workflow prioritization paper. Figure 4 is the core evidence visual. It compares receiver operating characteristic curves for the fusion model. In plain language, the paper reports that combining triage information with ECG interpretation improves the model's ability to separate more urgent from less urgent cases. The performance table makes the story concrete. The fused approach reports higher precision and F1 scores than the earlier single-source phases. But this is exactly where we should slow down. Retrospective model performance is a signal to validate, not a license to deploy blindly. Table 8 translates performance into outcome categories: major adverse events, ward admission, and discharge. These numbers are impressive within the study. The caveat is equally important. A 600-record, retrospective, single-study validation does not prove safe general use across emergency departments. So the practical interpretation is promising signal, not automatic deployment readiness. Before this belongs in a live emergency department, teams would need external validation, calibration checks, subgroup analysis, and careful testing of how clinicians actually respond to model output. Quick pause. If this kind of evidence-first breakdown helps you translate dense healthcare artificial intelligence papers into practical questions, subscribe and enable notifications. And comment below, would you trust Triage AI more if it showed the source evidence behind the recommendation? The second paper, by Hiratsuka and colleagues, is easier to miss because it is not a leaderboard paper. It is a symposium perspectives paper about artificial intelligence and machine learning in Alaska Native healthcare systems. That makes it valuable for governance. Table 2 is the key evidence visual here. It gives scenarios like a sepsis tool that has never been tested on local data and an early warning tool for elders living in villages. These examples turn artificial intelligence governance from an abstract ethics slogan into operational questions. The governance lesson is simple and difficult. A model can optimize a target, but a community has to help define what should be optimized. In rural and indigenous health systems, local validation is not optional. Geography, transport, staffing, culture, and trust all change what a model means in practice. Put the two papers together, and the theme is clear. Triage artificial intelligence asks whether we can prioritize the right patient faster. Governance asks who decides what right means. The future of healthcare artificial intelligence needs both workflow safety and community trust designed together. That is Healthcare AI Weekly for this week. In the comments, tell me which layer you think matters most right now: model performance, workflow fit, or governance. Subscribe for the next episode and share this with someone working on clinical artificial intelligence, operations, safety, or community health.